Good afternoon, everyone, and welcome to CDOC's quarterly Cancer Center's collaborative meeting. My name is Sheila Sanyo. I use she, her pronouns, a strategic alignment specialist for the Comp Cancer Program and the California Cancer Registry. While we are giving others time to settle in, please feel free to share your name, pronouns, organization, and share your favorite spring activity in the chat. Next slide. Again, please feel free to introduce yourselves in the chat so we can get to know who's joining from different cancer centers. So I'll go over some housekeeping while everyone is typing in their introductions. All participants have been muted. We encourage engagement and participation throughout this session. While the chat is being monitored for comments or questions, we'll have an open discussion allotted after the presentation. And then we also hope that you can answer a short meeting evaluation. Any slide deck or recording and follow-ups will be sent via email to all participants. Next slide. Thank you all so much for taking the time out of your busy schedules to be here today. Joining us are Cancer Center Community Outreach and Engagement leads and program representatives, CDOC leadership and other partners, American Cancer Society partners, and CDOC work group chairs. So before we start with the agenda and presentation, I'd just like to acknowledge our CDOC chair, Dr. Sora Tanjusiri from the University of California, Irvine, and co-chair, Dr. Allison Herman from UCLA Johnson Comprehensive Cancer Center. Unfortunately, they won't be able to join the call today due to competing priorities, and we'll go over with the agenda. So we'll hear some updates from ACS, Comp Cancer Program updates, including cancer plan revision items, followed by a presentation from the Indian Health Services. We'll also provide opportunities for discussion and collaboration and a chance to share and learn about other cancer centers events, research, and other updates, followed by a quick wrap-up. To provide American Cancer Society updates, let me introduce our ACS partner, Bridget Freely, CDOC Vice Chair and ACS Associate Director, leading state partnerships in California. Go ahead, Bridget.
Thank you so much, Sheila. And thank you all for having me here today just to share some American Cancer Society updates. So we can go to the next slide. So first off, ACS and Pfizer are excited to be collaborating to offer a new competitive grant opportunity that's focused on improving cancer care for American Indian and Alaska Native, as well as Native, Hawaiian, and Pacific Islander individuals in cancer treatment. This opportunity is not specific to one cancer type. It's really meant to assist oncology programs to implement QI projects to help reduce disparities and improve cancer care. The deadline for submitting full proposals is May 28th at 11:59 p.m. Eastern Standard Time. We do have an RFP available, so please contact your ACS staff partner if you're interested and want to learn more. I'm also happy to share any additional information if needed. We can go to the next slide. So, our ACS Lion, or Leadership in Oncology Navigation program, has an exciting new opportunity. And just as a reminder, ACS Lion is ACS's standardized training and credentialing program for non-clinical oncology navigators. So ACS Lion is now offering a certificate in clinical trial navigation, and it is available at no additional charge for those with an active ACS Lion credential. So you can enroll in ACS Lion or in the clinical trial certificate here in the QR code, or click on this red bar here on the slide. We can go to the next slide. We have a new report available in our Cancer Facts and Figures series. These are reports put out by our ACS research team, and it is focused on cancer statistics and information for African American and Black communities. We have the full research article available, as well as a fast facts spreadsheet, which is just really providing high-level takeaways that are easy to read and easy to understand from the report. And both are linked here, and I've also linked on the section on our website on cancer.org where you can find this information as well. We can go to the next slide. We've also launched a new cancer risk assessment tool. It's called ACS Cancer Risk 360, excuse me. This is available on our website. It's completely free to use and it takes about 5 to 10 minutes to complete. So what individuals will do, they'll go to this home screen here. They'll answer a series of questions, get customized tips and resources to reduce their cancer risk with information like healthy lifestyle recommendations, cancer screening information, genetic counseling, potential needs, and more. The link is here on the slide. Please feel free to take the assessment yourself and share widely with your networks. We can go to the next slide. We have a new prostate cancer testing shared decision making aid, really to help men decide if prostate cancer screening is right for them, as well as the importance of shared decision making about prostate cancer testing with a provider. We have this resource available in English and Spanish, as well as 12 other languages. And again, the handout really just discusses the benefits and limitations of prostate cancer screening and the importance of that shared decision making. We can go to the next slide. Our team has also launched two brief videos to help answer some of the most common questions that individuals going through a cancer treatment might have about fatigue, dealing with weakness, and symptom management. These videos are available in both English and Spanish. And my apologies, these red bars, sometimes the formatting gets a little bit messed up, but you can click on those or scan the QR code to access the videos as well. We can go to the next slide. The American Cancer Society and the Center to Advance Palliative Care have worked together to launch the Enhancing Palliative Care and Oncology program. And what this does is it will provide bi-monthly webinars and also resources for oncology teams. So the next webinar is scheduled for May 21st. You can register here at the QR code link or in that red bar there. Once you register, you'll also have access to past recordings and that resource library as well. And then lastly, for ACS updates, I just wanted to share a few additional resources. We have our Improving Treatment in Advanced Breast Cancer Echo series. The first session will be held at noon Eastern Standard on May 15th. You can register here at the link. And we also have a new guide, Building Capacity to Address Social Determinants of Health. This is a comprehensive guide that has resources for health systems, really to help better understand and address social determinants of health in the communities they serve, and then also get reimbursed for social determinants of health screening. The link to the guide is here, and it has great case studies and workflows as well. And I think that is it for ACS updates, but I did want to share a few high-level updates from our ACS Cancer in Action Network, or ACS CAN. So Autumn Ogden Smith used to be our ACS CAN rep for CDOC. She is no longer with ACS CAN, but we're working to identify a new ACS CAN contact as soon as possible. I know they're actively hiring for her position, so hopefully that new representative will be able to attend future meetings. And I just wanted to share a few high-level priorities that I received from ACS CAN earlier this year, and I'm happy to follow up if you have any questions or want any additional information. So the first relates to lung cancer screening. So they're actively working to advocate for all insurance plans, including traditional Medicaid, to provide a comprehensive benefit for lung cancer screening, which includes follow-up testing according to recommended guidelines without cost sharing or other barriers. They're also working on funding for Every Woman Counts, breast and cervical cancer screenings. ACS CAN is also supporting legislation that restricts the use of so-called copay accumulator adjustments in health insurance plans. So they're working on policies that will ensure third-party prescription drug copay assistance is counted towards patients' out-of-pocket cost obligations. They're implementing tobacco retail licensing fees and also opposing efforts that weaken smoke-free state laws and working to strengthen legislation that encourages smoke-free state laws. And they're also potentially setting up a childhood cancer research tax donation fund in California. So thank you so much. And I'm also, again, happy to get any additional information or status updates about some of those ACS CAN pieces as well. But thank you. And Sheila, I'll pass it back to you.
Thank you, Bridget. And I see a question from Shannon on the chat.
Yes, Shannon, that is a great question. I can definitely look in our resources to make get to ensure that we have those resources for non-binary individuals who might need prostate cancer screening as well.
Thank you, Bridget. To start off with some CDOC and program updates, I'd like to call our State Cancer Program Director, Shante Davis Patterson.
Thanks, Sheila. Good afternoon, everyone. Good to see everyone on the call and happy spring. Um, so today I'll be going over some of our CDOC up. Go to the next slide. State Cancer Plan revision. As most of you know, we've been deep into the cancer plan revision for several months since last year, actually the end of 23. And we're coming to the end. So we hosted our third cancer plan revision check-in on March 10th, which is our third check-in meeting where we have all of our subcommittees together. We have one left in June, but right now the subcommittees are finishing their final content to turn into us to get ready to consolidate and edit on April 30th. So again, we're almost to that finish line, or at least to the point where we'll be turning it in for approval in the coming months. And just a reminder for those, the new state cancer plan is going to be a new, or it's going to be a 10-year cancer plan this time around. So it will go from 2026 to 2035. We are anticipating an early 26 release. And you'll see on your screen there all of the subcommittees that are working on various topics that are within the cancer plan. So those are all of the topics which, and this year we are, our new section is childhood cancer. So we're happy to have that section that's added. And again, the rest you see there on the screen. And then as far as the timeline, as I mentioned, April 30th, we'll be receiving that final content. And then by December 25, we're working with the CDPH communications department to help us get it up on our website and get it out to everyone. So thank you, Sheila. And then one of our activities with colorectal cancer, we have a collaboration with the Every Woman Counts program and the California Colorectal Cancer Coalition. It's called the BSIP program, or the Breast and Colorectal Cancer Screening Implementation Project. We are now in cycle 3, where we are funding FQHCs in California who are also EWC providers to implement evidence-based interventions in FQHCs. We just selected 7 FQHCs that have started working in January, at the beginning of January. And you'll see all of the 7 listed there. And there was out of all of the clinics, the combined funding amount was a little over 120,000 that was dispersed amongst all of the clinics. And then also with our colorectal cancer work, we do have a work group that's working on a collaboration between Medi-Cal managed care within the Department of Healthcare Services, the American Cancer Society, as well as the California Colorectal Cancer Coalition, C4, to improve Medi-Cal colorectal cancer screening rates. We are at the point now where we're kind of compiling some resources, but we'll be planning to present some type of training or educational webinars on best practices and different ways that the Medi-Cal managed care plans can increase their colorectal cancer screening rates. So, and we anticipate that to be later on this year. All right, I think that's my time. I'll turn it back over to Sheila.
Thank you, Shante. For the Health Equity Work Group, they continue to work on the SOGI Plus Data project. As a recap, in 2022, we surveyed California cancer centers to determine TOGI plus data collection practices and identify pilot sites will enroll for the project. The patient survey was completed in April 2023. Our leads are currently doing data analysis. The patient survey assesses patients' knowledge and comfort with providing TOGI plus data. The next component is the Comprehensive Cancer Care Team Survey tool that was completed early this year. The component aims to identify challenges faced by the cancer care teams in supporting LGBTQI patients. Pilot sites have been identified, and we continue to accept any cancer site interested in administering the survey at their cancer center. The next component is the community survey. This is in collaboration with the California LGBT Health and Human Services Network. We developed a survey to gather data from the LGBTQI plus community. So the survey is now live, and my colleague Joyce will share the promotional flyers and toolkits you can share within your networks. Next slide. The survivorship work group will be working on the psychosocial support projects. The awards are rolling over to the next fiscal year, which we aim to begin in July 2025. We will continue to work with the cancer support community for this project. Another activity identified by the work group is to establish a cancer care specialty within the community health workers, promotores, representatives certification program within the CalAIM initiative that focuses on CHWs. So the aim of the project is to enhance the scope and impact of CHW certification initiative from cancer prevention, early detection, navigation, and support tailored to underserved communities. As for next steps, the CDOC is collaborating and coordinating with the California Healthcare Foundation to learn more about their initiative and to just prevent any duplication. Next slide. The CDOC team recently sent out a survey to help inform a behavioral risk factor surveillance system, or BRFIS fact sheet. The BRFIS is a state-based cross-sectional telephone survey conducted annually. It collects data on health-related risk behaviors, chronic health conditions, and use of preventive services from U.S. residents. So the short survey is intended to inform the CDPH Chronic Disease Surveillance and Research Branch, where Comp Cancer Program lives, on what variables or topics from the BRFIS 2022 would be of interest in development of a cancer-related fact sheet for use for Comp Cancer partners and the public. So if you have a moment, please complete the survey, which Joyce believe had dropped on the chat. The last webinar presented from our CDOC Cancer Surveillance Data webinar series was about the BRFIS overview in relationship to cancer data. So that session explored how BRFIS data inform the cancer plan measures we're working and provided a deeper understanding of its relationship to cancer data. There was also a presentation of the contents of the BRFIS as well as data to be collected in the 2025 survey. There was also a discussion of the BRFIS variables related to cancer and modules that could potentially supplement the cancer data. So you may view all BRFIS and all the webinar recordings at our CDOC site, which Joyce will be dropping in the chat. And then the CDOC Cancer Surveillance Series, it's really a virtual learning opportunity that will educate our CDOC members and the public on any cancer-related surveillance data sources. So the last webinar for this fiscal year will be held on June 18th, and the topic is about cost per cancer cases. The webinar will present findings from a quantitative economic analysis of the CCR, estimating the average cost per cancer case. The registration will be also dropped in the chat. And now I will pass it over to Joyce to give the remaining CDOC upcoming events and reminders.
Sheila. So the next opportunity is going to be on Thursday, May 29th for the CDOC orientation webinar. This is an opportunity for current and new or prospective CDOC members to become more connected with the coalition by learning important information about CDOC structure, focus on areas and activities, and the webinar will include an overview of CDOC's mission and structure, where and how we focus our efforts, updates on the state cancer plan, opportunities to join work groups, ways to get involved in collaborative projects, and I'll go ahead and drop the registration in the chat right now. Next, in June, we have a evaluation webinar. That's going to be June 5th at 12. This session will highlight the findings from the CCCP 23-24 evaluation report findings at a glance. And this will provide some insights on how CDOC Coalition tracks progress and strengthens cancer control efforts across California. Attendees will be able to learn about how evaluation supports planning, collaboration, and continuous improvement across programs and partnerships. And I will go ahead and drop those in the chat as well. And then next, our next HPV vaccination learning collaborative is going to be on July 16th. This is a lunch and learn opportunity, which includes teaching segments from HPV vaccination experts, field updates, and open forum for sharing best practices, challenges, and announcements. If you'd like to present and you can share HPV opportunities from your cancer center, please send an email and we'll provide any relevant informational links in the chat as well. We also want to remind everyone that CDOC welcomes all members to spotlight their work or recognize individuals who have done work in cancer control. We encourage you all to share information about your projects and any outstanding members by completing a form. Submission to be featured in the CDOC website, listserv, and other communications. And then I will go ahead and drop the chat so that you can learn more about the member spotlight. And I'll pass it back to Sheila.
Thank you so much, Joyce. In today's presentation, we have the pleasure of hearing from our partner at the Indian Health Services. Anna Knight currently works for the IHS California Area Office of Public Health as a clinical healthcare consultant and began this role in April of 2024. She has been an RN for 28 years and the last 11 years as a nurse practitioner. A hallmark of Anna's clinical work has always been built on a foundation of quality patient care and advocacy. Her clinical experience spans the vast realm of family practice, urgent care, internal medicine, and nephrology, where she was able to innovate transitional care management of the most chronically ill patients to prevent ER visits, hospitalizations, readmissions, and have hard conversations with patients and families about end of life decision making, giving patients more quality time at home with their families. She has brought this same passion and energy to her consultant role, hoping to have a positive impact within the state. Anna is married with 2 children and 3 grandchildren who are her pride and joy. When she is not en route to one of the 66 tribal or urban clinics in the state for a site visit or special event, she works remotely out of her home in Temecula. Her favorite things to do include being outdoors, either camping, hiking, foraging for plant medicine, or gardening. Please welcome Anna Knight.
Thank you so much for that introduction. And I want to just open by thanking CDOC and the Comprehensive Cancer Centers for this opportunity to present on Indian Health Service operations for California. I want to again apologize for our abrupt cancellation of the presentation last quarter due to the changes in the administration for federal agencies and their communication as we've been faced with rapid and sometimes unpredictable directives. So I am happy to report that today Indian Health Service, knock on wood, has not experienced any reductions in force yet, and we absolutely, as one family, remain steadfast and laser focused on moving forward with our mission and our vision. And if anything, the past 3 months has emboldened us to act with even more intention. So thank you very much for having me today. I want to start before I jump in. I think it's important to highlight, thank you to Dr. Kim Ashing over at City of Hope for inviting me to participate in the AACR meeting last year. It was my first opportunity to ever kind of talk about my experience as a cancer survivor, and it is important to who I am and what I bring to the table. And so I do want to share that in 2013, nearing the end of my graduate work, I found myself without health insurance and took advantage of a mobile mammography clinic in clinic one day. And I was so completely surprised when I was told that they had found something suspicious that needed further evaluation. And so in somewhat of a panic, faced with the reality that here at the end of my program and all this hard work, I'd find myself hijacked by a cancer diagnosis. And so I actually was pretty helpless, but I did have some resilience that I leaned into with my native beliefs. And I reached out to one of our traditional medicine people back home in Northeast Oklahoma for help. And meanwhile, I did everything I needed to do on my end, which was enrolling in Every Woman Counts, scheduling my testing, and showing up, and held my faith that everything would be okay. And on the day of my tests, after completing them, the radiologist pulled me aside and shared awesome news that they found nothing. Clearly showed me on the mammogram films where there was something, but now it was gone. And I just smiled and nodded, knowing exactly what had transpired. And I share this story just to highlight that, you know, as Indigenous people, our ways of healing and health were deeply and profoundly affected by having these things outlawed, and we were not allowed to practice these ways for many, many decades. And this is just one of the obstacles that we encounter in just trying to exist in the two worlds that we live in. Unfortunately, in 2020, I did become symptomatic and was diagnosed with endometrial cancer, which luckily was graded and staged as 1A. And I'm now nearing the end of my surveillance, and it will be 5 years for me on Indigenous Peoples Day this year, which is no mistake. So it's with both humility and gratitude that I find myself here today to do my very best to explain Indian Health Service to you, where we are at in our work, maybe some insights for opportunities to support our programs and people in California. And then if I completely fail to answer any of your questions in my presentation, I hope there's going to be time at the end to address any questions at the end. So go ahead and change slides for me, please. So our mission and vision are here for you. I don't want to read the slide for you, but I do want to explain that Indian Health Services federal direct care services are administered through a system of 12 area offices and 170 service units across the country. While we have not received any recent updates, there is some chatter that these 12 areas may be condensed much in the same way that the Department of Health and Human Services regions were recently condensed. More than 60% of the Indian Health Service appropriations are administered by tribes, primarily through what we call self-determination contracts or self-governance compacts. Title 1 and 5 of the Indian Self-Determinations and Education Assistance Act allows tribes to exercise their right to self-determination by assuming control and management of programs that were previously administered by the federal government. And in California, we never really ever had any federal facilities because, you know, as colonization took place from east to west, you know, California, the West Coast was kind of the last to be colonized. The Indian Health Service enters into limited competing contracts and grants with 41 urban Indian organizations to provide healthcare and referred services for urban Indians. The urban Indian organizations provide access to culturally appropriate quality healthcare services such as ambulatory care, outreach, and referral and residential and outpatient substance use treatment programs. The HHS secretary recently has proposed an $897 million cut to our fiscal year 2026 budget. And most of that 897 million is going to come out of our direct services. So I would expect to see that expenditure per user population to decrease. Tribal leaders have been in session with HHS leadership yesterday and today as we speak. They are actively advocating for consultation and advocating that services that have been closed down because agencies that deliver services to tribes have been shut down over the last 3 months. And there's some little discordance going on about what consultation means and what it looks like. So equally concerning to the tribes, particularly in California, is the lack of consultation that is taking place between state and tribal leaders who actually just met yesterday for several hours. Much was said, and of course, if you can imagine, with talks about decreasing funding amounts to Medicaid, tribal leaders' paramount concern is those funding dollars. So we always hope that our messages are received and heard, and that change will follow. Next slide, please. So it's hard to read this. There's no easy way for me to put it on there to make it look better, but I think you can get a feel for the state and where our programs are. California tribes in particular, as I mentioned, have historically faced a higher load of burdens associated with termination of their tribes by the government, having a fight to be reinstated and recognized federally, and all funding and services for natives stems from that federal recognition. So the hallmark of our tribes is that they are predominantly located in rural areas with notably sometimes few members residing in the area. And due to the challenges and necessities of providing care, several California tribal programs have decided to open their programs to non-native beneficiaries. And this typically is a win-win, especially in rural California communities where provider shortages are common, and it helps to increase third-party revenue for the program, which then allows for greater recruitment and retention of quality providers. Next slide. So we know that in California, we have a troubling increased age-adjusted cancer-related mortality rates. I think the last numbers were 3.8% and trending upward, whereas all the other minority groups are trending downward and well below 2%. And so when we look at the age-adjusted mortality rates for breast, prostate, lung, colorectal, pancreatic, and liver cancer, American Indians, Alaska Natives, as a minority, have the highest rates in comparison to those other minority groups. Next slide. So this is just a quick slide that I put together on what's taking place nationally with Indian Health Service. And so back in 2023, when we were under the Biden administration, President Biden at that time had initiated the cancer moonshot. And so there was some chatter and hints and hopes that we would get some funding from that, and it never happened. But we continue to push forward with that work, typically utilizing public health funds and some ARPA funding. The cancer work group did come together towards the end of 2023. They drafted a plan. The plan was required to be submitted to CDC for approval because CDC had some MOAs with tribes. They wanted to make sure that everything was, the language was consistent. The plan came back to us. We realized we weren't going to have funding for that plan, and so we changed the title from a plan to a blueprint, knowing that the intention was to get the information and tools into the hands of federal, tribal, and urban programs. And so, as you can see, we have a drafted vision and mission, and the plan blueprint was scheduled to go go back to CDC. Unfortunately, I don't have any updates. Probably right as we were getting ready to hand over that blueprint back to CDC, again, there were staffing changes. And so I don't have any updates to that blueprint as of today. Next slide. So the budget was set for fiscal year 2026. For those of you who don't know, like our federal budgets are typically set at least 2, sometimes 3 years in advance. And we were hoping to get funding for fiscal year 2027. But with that massive cut of $897 million, I am losing hope that will be funded specifically for cancer, but I'm not going to give up completely. We have continued to move forward on the dashboard. It is progressing, and we hope for it to go live by the end of the year. What will be consistent on the dashboard is it will be populated with IHS federal, tribal, and urban site-specific information regarding the facility, what specific screening, diagnostic, and treatment information are provided there. And then in addition, for areas like California, we expect to also be able to include non-tribal and urban treatment locations that we refer patients to. And so I'm looking forward to see how that translates for California. Probably the most positive, exciting news comes with the knowledge that I will be shortly receiving navigation funding from our public health budget at headquarters. It looks like we'll be receiving about $80,000 in support of navigation throughout the state. We are on a tight schedule. These funds have to be spent by the end of the fiscal year 2025. We'll be utilizing the George Washington University Navigation Program and partnering with some folks at UC Davis who initiated the California Native and Indigenous Cancer Task Force late last year out of Dr. Carvajal Carmona's lab. And in February this year, those same people did provide an American Indian Alaska Native Cancer Academy to a representative group of tribal programs from Central and Northern California, and it went really well. So we're going to incorporate that as part of our navigation training. Sadly, I'm sure just as you are all learning, we have been getting word that much of the federal funding for so many of the research awards in place for Indian country are being terminated. And so I'll come back to this navigation piece in a few minutes. In terms of our colorectal cancer toolkit release, this also has been impacted with the effects of the new administration, but the work continues. We did successfully debut our inflatable colon in March of this year at our tribal leaders meeting. It was a big hit. If you can imagine, when the folks were coming and going from the main meeting room, in order to go to the restroom, they had to go through the colon, which was hilarious. And they loved it. And so we have been getting requests for it at health fairs. And in fact, tomorrow I'm flying up to Sacramento to attend a health fair up in Oroville with our Feather River Tribal Health Program and bringing our inflatable colon as well. So good movement there. Our tobacco prevention and cessation work takes the form of 3 different programs specifically. We being Indian Health Service, developed a program called the Sacred Circle of Tobacco, which focuses on teaching Native youth about ceremonial tobacco. We have a saying that culture heals, so reinculturation is a protective factor for our youth specifically. And tobacco, for those that aren't aware, tobacco is one of our first sacred medicines. And when our youth are taught this from an early age, they're less likely to engage in use of commercial tobacco use. And secondly, we've deployed Catch My Breath, youth vape prevention program in our communities, which is the only SAMHSA endorsed vape prevention program developed by the University of Texas. Curriculum is evidence-based, very user-friendly, and free to any program staff that work with youth. I provide that training on demand and quarterly to those interested. And in addition, for now, knock on wood, we have a contract with the University of Arizona Healthcare Partnership for American Indian Alaska Native basic tobacco intervention skills, offering all 3 levels of training to federal, tribal, and urban program staff. And I'm always actively advertising this and encouraging them, and trying to get as many of our programs in as soon as possible, because as I mentioned, we don't know how long we'll have those contracts funded. Not listed on this slide, behind the scenes, I continuously offer consulting support to our programs to help them address issues around improved screening rates and referral follow-up. Every site visit that I make, I'm actively engaging them as to their process, looking for best practices to share, and supporting them with patient-centered tools to increase the screening and early detection rates. Next slide. I am so grateful to all the organizations and people on this collaboration list, and please know that this is not an exhaustive list, but without these folks, I wouldn't have had such a successful splash into the realm of cancer care when I started this role 1 year ago. When people oftentimes, I as a caveat, I want to just mention this. So many people reached out to help and support and hold up our American Indian Alaska Native community, and I take this message and I share it with our tribal leaders and the tribal community so that they understand the open arms that are here at CDOC. And I just would add that when people reach out, sometimes there's a notion or perception of what needs to be done for our communities. And so for those that haven't had any experience working in Indian country, it can definitely be perplexing and challenging. Our people and our programs work very different than most others, and it's mostly stems from that historical trauma and an intense mistrust of not just the government, but also institutions as a whole. That have maybe historically not always been friendly towards them, or have historically caused harm. And so please keep in mind that when reproaching us for our program, know that meeting in person and face-to-face dialogue is so critical. We don't do surveys well. I had that conversation yesterday because the state meeting, they were talking about, oh, we put a survey out, we got 9 responses. You know, we have 109 tribes in California. Why did we get 9 responses? We do best when we sense that you care and you have concern and you come to us first and you participate, you observe, you listen, actively listen. And I know that sometimes to some this feels like inconvenient, but understanding that one thing on the front side will take you a long way into the future collaboration, and be patient, and I'm happy to help facilitate any of that for any program that's interested. Next slide. So in terms of California activities, I would just say that, as I mentioned, ongoing outreach, 365 to all of our tribal and urban programs to encourage participation in CDOC. I know they're starting to trickle in one at a time. Ongoing sharing of those funding opportunities. I want to thank that recent RFP that was just released. I know that I have people interested in talking about submitting. And I'm so happy to see that Santa Clara was included in the breast and colorectal cancer screen. I'm actually going to be going up there soon for a program visit. So I'm so excited to hear that. Ongoing collaboration for subject matter experts to present at virtual and in-person meetings for clinical staff education is a wonderful tool that we have for our programs. I do the CATCH program, the Youth Bait Prevention, the BTIS. We have a Just Move It campaign for increasing physical activities. And then I didn't correct this, but this presentation was for last quarter. As I mentioned, we had the debut of our inflatable colon. And the one correction on this last bullet point is our best practices conference has been moved to the first week of November. It is locked in by contract as of this week. And I would love if any of the comprehensive cancer centers would be interested in tabling at this event. It's primarily geared towards medical and behavioral health staff. So I want to also mention, if you'd like me to arrange for a meeting with any of the tribal urban programs in your catchment areas, If you already haven't, I'm more than happy to help facilitate that as well. Next slide. So my dream state. Here's just the two big helicopter dream states for me that we have tribal leaders and community members that are engaged and in collaboration with the state, county, and the comprehensive cancer centers and other community stakeholders to effectively reverse that incidence of cancer and the age-adjusted cancer mortality rates for our population by 2035. In addition, I would love to see American Indian Alaska Native representation on the comprehensive cancer community advisory boards. And I would love to have collaboration in our navigation programs moving forward. So I'm definitely open to any and all supportive and any hands that are reached out to help our people across the state from the top to the bottom. Next slide is just my references, and next slide for my thanks. Here's my QR code with all of my contact. Part of some of the administrative changes was return to office. So I did enjoy telework from home for a year. I returned to the office. I'm housed in Escondido now with our Office of Engineering folks at IHS here in California, and but travel frequently around the state. I just want to thank everybody and happy to answer any questions that anybody might have.
Thank you so much, Anna, for your valuable presentation highlighting the cancer burden among Native Americans in California and the important collaborations and activities advancing this work in this state. With this, I'd like to open the floor for questions or comments, so please feel free to raise your hand, and I will start off reading the comments that we received on the chat. We have a question from Dr. Anderson. The Indian Health Service National CRC screening rate in 2023 was 23.3. Do you have any update on the California cancer screening rates for breast, cervical, and colorectal cancer in 2023 or 2024?
Thank you, Dr. Anderson, for your question. I have not seen the updated rates, but I am not the GIPRA person. And I know we've had this conversation before, but for the purpose and intentions for everybody else who might not be aware, we have a quality measurement tool called the Government Performance Results Act. Those are indicators put in place by Congress to kind of demonstrate that we're doing what we need to do with the money provided to our federal and tribal and urban programs. And so for California, all of our programs are tribal or urban. We only have 2 federal facilities, and they're both youth regional treatment centers for substance use treatment for Native youth and co-occurring behavioral health disorders. And our tribes are strongly encouraged to report their GIPRA indicators, which are very similar to the HEDIS measures. I actually this year encouraged them just to drop the GIPRA and stick with the HEDIS. And the reason is really our data is not clean. All of our programs use different electronic health records, and not always do those electronic records process the data into the GIPRA, or can they get it out the way they need to, the way most EHRs are geared towards providing the HEDIS measures. And so I'm happy to communicate that information back, but I know I can tell you that the data is not clean. And actually one of our local programs that Dr. Ndora works with, Indian Health Council, I work closely with them, and he can probably attest as well that their measures probably don't translate well. And they just switched to the EHR in addition to that. So our measures typically, this is the thing that's perplexing to me. So people don't do what you don't measure. I actually went back when looking at the data where I can't remember which indicator it was, but we were making just barely making our screening rates. And I express this all the time to many people's disdain, I'm sure, is like anything less than 100% for screening early detection feels like genocide to me. So I'm like, why are we just asking for 34% or whatever? But when we raised the rate for one of those screening, it went up. And then for whatever reason, somebody decided to lower it and then it went down. So that's why I'd like to see just 100% expectation out there for performance with the GIPRA. And because anything less is unacceptable for me. So,
Yeah,
thank you for that question.
sure, Anna, Stoney. It's interesting, the screening rate target on that report for colorectal cancer is 23.7%. But you know what? I would hope that you can find one of your tribal groups that has done well in one screening, and they report, breast and cervical are in the 30s, that have done well, and try to mine that information to spread it to the other tribes is the reason I really was asking the question.
Yes.
So hopefully that
Yes.
can happen.
Yeah, so last year we did a couple pilot studies, not in California. It was before I came to work here, but they piloted some studies to take a look, and the breakdown always just seems to be in the staffing and management of closing the loop on the referrals, and somebody actually going after the population who are due and just getting that ball into the zone. And so when we apply that, it works very well. In fact, most of the pilots were able to increase their numbers by 20 to 30% just by having a champion and a concerted effort. And so on the back end, my job is always trying to translate that for the programs. How can we dangle the carrot in front of them to do these things? And part of that has to do with the navigation funding. And so that's why I'm really concentrating right now. We have a short time to get this done, but I'm really concentrating on making sure that we handle the reimbursement piece and we answer that question for our programs, because they need to do a better job at billing for their CHW services. But also, if I'm gonna be rolling out this navigation training, I want to make sure it's perfectly clear to them on how they can capture reimbursement for navigating to screening and diagnostic, and then actually, treatment services and the like, so that we can encourage them to fund the staff that need to do the work.
This is Kimlin from City of Hope. Anna, thank you so much for your work and leadership and advocacy. A couple of thoughts or questions. In terms of data, as we were talking about, what's the best data source for cancer statistics for American Indian, Alaska Native groups? And along those lines, are there talks or consideration for a partnership with ACS to put out a cancer facts and figures for Native American, Alaska Native? With the CHW very, very passionate and interested in that, in terms of increasing their capacity for community-based oncology work. So just, very interested in that component, and happy to help, and also to consider how we implement and activate the community to know about SB 987, the Cancer Care Equity Act. And that's for, those with complex cancers and such. It got watered down by the final signing, and it's still in process. So we do want more advocate and leadership organizations. It may not be Indian Health Services, but other Indian focus advocacy organizations to partner with City of Hope and the other coalition to bring that law to life for the Indigenous community. And that could be part of the training. How do we activate patients who may be eligible to know that that's available for them? So I know it's a mouthful, but.
Yeah, there's a lot of questions there. So let me work backwards from that last question. Probably the best way to educate is a couple different platforms. We have a monthly office hours, our Office of Public Health. So if you would be interested in talking about that, happy to host you to do that. And we're planned out. I have a speaker coming in June on colorectal cancer, but even for July, if you would be interested in getting online, we typically, I don't know, sometimes we have great participation. I try to advertise it and get the word of mouth out there so that people can plan and prioritize showing up. We do record it and send it out. So that's one way. Another way is at our best practices conference is that I'm really hoping to just kind of blast all things cancer out there, because I want to saturate our programs with the support, on the other side. So that we are linking our folks to the best places for care. I personally know what it means to, as my mom had in, what was it, 22, been diagnosed with squamous cell esophageal cancer. And because, she was in a community not close enough to a comprehensive care center, had a procedure that ultimately probably seeded and caused her metastasis before we had even begun treatment. And so I know the importance of the comprehensive cancer centers, and part of the training, and that's one of the other asks is my goal is, and the 2-day in person, I would like to do a field trip and bring these folks to a center where we're doing the training, and near to where we're doing the training, so that we can show them, all the benefits of the comprehensive cancer centers. And so, right now we're looking at 2 sites, San Diego and the Davis area. And so natural partners would be UCSD and UC Davis. But I would also, say that we have lots of other programs that have catchment areas, that are in other catchment areas. So I would like to offer that as an option too, just to normalize that and raise the bar and the expectation, because the outcomes oftentimes are not what they should be because maybe they didn't get into treatment fast enough at the best place for them. A lot of that also, we are talking about also trying to inform and educate people about participation in clinical trials. My uncle is a great example. He had a very rare sarcoma, went into a clinical trial. So we want to capture those success stories in digital storytelling, to raise the bar in there. In terms of the data, I want to hit that point. So just know, like probably the best place, your best resource is going to be from your state, your county. UC Davis did some great work for us here in California. Nationally, if you're interested, I would say Indian Health. At the local level, there's an issue, and I don't really want to make it out to be something that it isn't, but just so that you have an awareness. Data sovereignty is a very real concern, and the tribes, when they participate in research programs, and first thing coming to mind is Indian Health Council that Dr. Nadar has worked with, and their scientific advisory board. When they have data, they meet and they come together as community leaders to make decisions about how that data is shared. And that's an important piece of sovereignty for them. And so I would say that, lean into what's available at your county and the state and nationally. Know that sometimes racial misclassification is a real thing. We get lost in a lot of things. I mean, I had folks in my family who are, half, 3/4 full, who check the box as Caucasian. So it can not be clean data there too. So just knowing that. I hope I checked off some of your important questions, Dr. Ashley.
Thank you.
Thank you.
Thank you, Anna and Kimlin. Before I go to the hands raised, I just like to address about the data. For cancer statistics for Native Americans in California, the CCR does produce cancer incidence and mortality rates. CCR data are linked to IHS to decrease misclassification. And then I'll go over and Margaret, I see your hands raised first.
I have to come off of, thank you. Whoops. Thank you. Mine won't be nearly as long as Kimlin's. I will make one plug since Mark is on this call as to when are we going to see the most recent cancer data being released, because we're still sitting there at 2021 for the cancer registry release. And a lot's happened in those years. But for Anna, sorry, was on a previous call with Anna. So for Anna specifically, and I was just on the IHS site looking at the GRIPA, and it indicated for the colorectal cancer toolkit that the focus is still on 50 to 74, and it didn't have a date. So I don't know has that been updated? So you dropped the age, because we know on even the 2021 data that the rates are going up under 50. And so there's that concern, right?
Yeah, so thanks for that question, because it is still in with the subject matter experts. They did drop the rate down. Actually, they went below 45 to 40. And my question is like, how do we impact, reimbursement and billing is an issue. And so, but that's being worked out by the subject matter experts at the C-suite level for IHS right now.
Great, thank you. Yeah, I think one of this, and I don't know how it relates specifically to the AIAN population, but one of the, the under 50, the data that I saw suggested that 50% of those under 50 that are diagnosed with colorectal cancer are diagnosed under 45. So
yeah,
maybe hitting it at 40 is not a bad thing.
Well, I think that's what the consensus was, but we just need leadership to get on board and then do their advocacy and influence.
Payment's the issue too, right?
Mm-hmm.
Thank you.
Thank you. And Mark, I see you go off mute. Do you have any answer for Margaret with regards to CCR data becoming available?
I went off mute because of the question that came up. I know that we've had some national data just coming out recently. Of course, this is, but I wanted to defer. Could Sandy? Oh, there's Sandy. Just put it in the chat.
So the data, sorry, Mark,
yeah,
the data
thanks.
should be released in May. This year it has been released later than previous years, just due to data cleaning and making sure that the data are appropriate after we migrated to CRDMS. So this year it should be released in May, and we hope to have products after.
Thanks, Sandy. Sandy is the subject matter expert here, so I didn't want to go any further. I just while I had the moment, I just shared the cancer burden among Native Americans report that UC Davis did that Anna had referenced to a minute ago, just so it's there for people. It's not really recent, but it was they did a good job. Thanks much, and thanks, Sandy.
Thank you so much, Mark and Margaret. And then Jesse, go ahead.
Yeah, thanks. Just to follow up on Kinlan's question, my take, having worked with tribes in Arizona and here in California, is that the best way to look at data, not necessarily use it, is it's a tribe by tribe scenario. And I can tell you that it's particularly the compacted tribes that control their own health systems. Most of them have pretty good EMRs. The tribe that I'm working with is migrating over to Epic, Ocean Epic, which is a very advanced system. And we're talking about 60% of the tribes roughly keep in mind that the urban American Indian health centers tend to be a combination of federally qualified health center and IHS type facilities. So they also have complexity in their data. But for cancer screening, I see two big caveats. One is that they would need resources. All of these programs would need resources and a focus um, on doing queries for that data in a consistent way. That's way beyond the GIPRA. GIPRA, for any of you who have ever worked with GIPRA, it's dated. It's like 50 or 100% lower than national standards in terms of what they're trying to reach. So it's more or less useless at the end of the day. But so that one caveat of resources for the focus, I think, is where leadership and dialogue and partnership really comes in. But the other big caveat is that none of the tribes are likely to want to report tribal rates for their tribes because of these issues that we've talked about related to sovereignty and so on. I think tribes may be willing to entertain aggregate tribal data where you couldn't identify a specific tribe, which means no identifiers whatsoever, no geospatial links or any of that would allow you to draw down. So all these complexities that Anna was talking about with regards to working with the tribes are very real, and unfortunately, it's going to take years to get to the point where you reach data sharing agreements and that kind of thing to get at like this aggregate data. But for comprehensive cancer centers that are interested and committed to working with tribes, my recommendation is find out which tribes you're interested in or programs you're interested in working with. Get a hold of people like Anna who can chaperone the way, or others, and go slow, listen, try to develop those partnerships and work with that tribe on their issues, not work with that tribe to promote, to publish papers. And those are kind of my lessons learned. And even then, I will, I will say it's not about you or us as outsiders, it's about them. And that's, that takes, like I said, a long time. But so it's basically, it's not a 1 year, 2 year project. It is a decade plus project. And just keep that in mind because that's the reality. So just wanted to share that.
Thank you, Dr. Nora. Thank you.
Thank you so much, Jesse. And then I also like to highlight Jesse's comment on the chat. It's informational session about real-time advocacy. And the link has been posted on the chat. And then I'll read off the rest of the questions. Margaret had a question. Since you have a contract for the October conference now, where will it be held?
Yes, it's still going to be in Carlsbad. I want to say, I think it's the Westin in Carlsbad, the first week in November.
Thank you, Anna. And then we have a comment from our partner from ACS, Raquel. The California HPV Vaccination Roundtable was given opportunity to present on the May office hours, and very excited to have Julie Dang from UCD as the featured presenter.
Yes, thank you for that.
And another comment from Raquel. I agree. It would be great to have a specific ACS cancer facts and figures publication for AIAN individuals. The 2022 publication had a special section on the cancer in the American Indian and Alaska Native population group. And links have been posted on the chat. And thank you for posting the link, Mark. And then Stony also has another follow-up comment on the GPRA website. They do give the 2023 California CRC screening rate. It is 13.4%. So with the low rate, the FluFit program would really help.
Yes, we actually we did partner with industry. Exact Sciences was at the tribal leaders meeting in Santa Ynez in March. in addition to the debut of the colon. And so there was a lot of conversation around that, and it's going to continue. The colon is such a great impact for the communities, and yes, we're going to be. I think it was Dr. Asma Shaukat from NYU that Dr. Hitchcock was able to connect me with. She's doing our office hours presentation June 2nd, I believe it is. And so as much as I can push all things cancer out to the group, I do that. And so, as I mentioned earlier in the presentation, would love to have people come table at our best practices in November. If you're interested, please reach out and contact me, and I'll get you the form. There's no cost associated with it, and it's a great location this year. So
Go ahead, Margaret.
So one thing, well, C4 will be there, Anna. We've already committed in some fashion. We'll talk about that later. One other thing was, because Stoney mentioned it about the mailed flu fit program. That was on the National Colorectal Cancer Roundtable under the resources section, and they recently pulled it. And so, and Raquel's on here, and we're not exactly sure why. But since that site is co-hosted by CDC, and whether it's maybe having to be scrubbed of certain language to be in compliance with CDC federal restrictions, is why we're guessing it's offline. But if anybody needs it in the interim, I have a copy. So just as an FYI.
We have Mike Potter can help you if you need help. He developed it.
He doesn't like talking on that anymore, Stoney, though, so he hates being asked to present on that.
Thank you so much, Margaret. I don't see any other questions on the chat or any hands raised. Great. Okay. All right. Thank you so much again, Anna. We're so grateful here at CDOC for this partnership with you, and we look forward to more collaboration ahead.
Thank you so much.
Thank you so much. I'd like to open the floor for any Cancer Center updates or Cancer Center representatives on the call who would like to share any resources or updates. Joyce will also drop the Cancer Center's shared Google Suite link in the chat if you prefer to list your events in a template, or feel free to email me directly, and we can also forward that in our listserv. Margot, you have another comment, and it says, in case that it may be helpful for fellow practitioners in Southern California, their team at UCD creates community snapshots, and she's sharing the latest snapshot for AIAN community here, combining ACS, county data, and other resources. Thank you so much, Margot. All right, so thank you, everyone. I don't see any other comments on the chat. As a quick reminder, we'll maintain the quarterly format for the collaborative meeting. All the 2025 dates are shown in the screen, and the Cancer Center hosts are identified alphabetically, with the next host yet to be determined. But if you would like to present a project from your Cancer Center, please email us at CDOC or any one of us at CDOC. Please complete the short evaluation webinar, which has also been dropped in the chat. Again, we will email the slide deck, any follow-ups, and the meeting recording as soon as they are ready. Thank you once again for sharing your valuable time with us today, and we look forward to your continuous collaboration with all of you. Thanks, everyone.
Thank you all for joining.
Thank you.